We're going to talk about morcellation today. The first thing we're going to talk about is the relevance of the topic. We'll go through some lay media. It's been in Wall Street Journal. It's been on TV. Patients are asking about it now. SGO's come out with a statement. FDA's come out with a statement. AEGL, which is a laparoscopic society, has come out with a statement. And then we'll finish with the FACOG statement, which kind of sets the minimum standard of care, I would say, now with morcellation going forward. We'll talk about why it became so relevant recently, and we'll talk about how it's always been an issue. We'll kind of talk about the history of it. I think the first morcellation procedure described in the literature was over 150 years ago. And Dr. Unger may know some more history about vagus and morcellation that I couldn't find. We'll do just a brief literature review today. We're not going to get too deep into the literature. You can find a million case reports and studies on dissemination of fibroids, endometriosis, and other things with morcellation. There's lots of studies, varying studies on retrospective studies on the incidence of sarcoma, which we're going to kind of talk about today. So I'm just going to give you just sort of a taste of some of those, not go too deep into that. We're going to talk about the complications of morcellation and have a couple of pretty good papers on that we'll discuss. As we'll talk about the incidences of occult malignancies. As I go through the presentation, have them highlighted, and I'd like y'all to look at the varying numbers that are thrown out there. They're pretty similar, but different organizations are given different numbers to counsel your patients on. So that'll be something that y'all have to decide going forward. Do you want to quote your patient 1 in 1,000 risk for a fibroid to be cancerous? Do you want to quote them 1 in 400? So it varies a little bit. So y'all have to kind of decide on that too. And the data's not real good there either. We'll talk about future considerations, and I'll kind of allude to some of those as we go through. And then we'll talk about the last two things are probably the most important two things of the procedure, the lecture. We'll talk about the informed consent process, which I admit I have done zero of with my patients in big uteruses. It's not something I've thought about until all this came out. And it's probably, I know Baker said that she consented one of ours a while back, but I know I haven't told any of the residents to do that. So that's something that we probably need to do as a department with these big uteruses, even though we're cutting them up vaginally, is to talk to the patient and ask them what they want, and have that in the chart. And the last thing, we'll go through the FACOG opinion, which is pretty in-depth, especially for FACOG, which doesn't really usually get too specific with things, but they give some pretty clear, at least minimum things that we should be doing, and possibly document in the chart. So we'll go through that. And at the very end, I'd like to get some discussion from some of the faculty on experience, and Dr. LaCour and I were having a conversation about some other things related to this out in the hall before, so hopefully we can stimulate some good conversation. So just to talk about, we talked about the lay media and how this has all come up. This is, I think, probably the first place I saw this recently in our little, these are our sort of kind of lay journals that we get. They're actually pretty good, and they kind of give you the pulse of what's going on in the field, and usually you can kind of look at these. And then the peer-reviewed journals seem to kind of mirror what's going on in these as well. This was back in, I think, March and April, all this started coming up. So how this all came about, I would say the biggest publicity push for this has come from these two doctors in Boston. Has anybody heard about this? Okay. So this is really a sad story, actually, and they have a website, has a video. It's very sad, shows all of her and her children. But basically, there's a guy that works at Harvard, Brigham and Women's, and he's a cardiothoracic surgeon. His wife's an anesthesiologist at a different hospital in Boston. She went in with like a 16 to 18 week size uterus, got a laparoscopic. She may have had a supracervical, but at any rate, she had morcellation. The pathology came back sarcoma, and she got staged like a stage 4 or something, and she was on the very high end of the staging, and mortality went way up. So he basically started a crusade against morcellation, and this has been in the Wall Street Journal. He's been on all kinds of TV shows, all this, and he basically threatened to quit Harvard unless they put a moratorium on morcellation, and really kind of put him and himself out there, and has affected some change. So if you want to know more about that, y'all can read these articles. They're really interesting. This is a video on Wall Street Journal you can actually click on. We won't watch it though. So this is the couple. Her name's Amy Reed. His name's Dr. Human. It's just some of the stuff I just mentioned. And they have 4 kids too. So when you start watching the video with their 4 kids and everything, it's pretty kind of emotional. So, all right. So this is another article out of the Wall Street Journal. Same deal. A guy and his wife. She was had sarcoma, and it was upstaged tremendously because of morcellation. All right. So this is New England Journal of Medicine, Journal Watch. This is like before the journals come out. Sometimes they issue kind of these teasers. And the 4 Boston physicians that are seeking a moratorium on uterine morcellation, I just talked about that. But they claim to have an article that's not out yet, that's coming out, that claims a higher than expected number of women with nearly 1 in 400. So that's one number to put in your head right now. This study's not been published yet, so this is supposedly coming out. And why they're making such a big push, because they're saying that the original incidence that we thought is not as high as it really is. So the interesting thing right here is they kind of give the opposite, not the opposite perspective, but a different perspective. FACOG maintains that morcellation is very low risk. Okay, this was back in February or March. FACOG initially came out with a statement, and then they updated it in June, so they have a brand new one. And FACOG has actually gotten a little more aggressive. They're not really saying very low risk like they did in the beginning. Okay? So this is off the SGO website. Another number I just wanted to point y'all out. This is, they claim fewer than 1 out of 1,000 women who undergo a hysterectomy for fibroids. And most of the studies are in the face of fibroids. It's not just all comers to hysterectomy. Most of them are people with known fibroids before the procedure, and that's one of the reasons they were having it. So they're saying fewer than 1,000. So that's a big difference than 1 in 400.
I want to say also that one of SGO's statements was very specific about patients who were undergoing surgery for rapidly growing fibroids, and it was still a lot lower than you would think.
Yes, and FACOG mentions that too, and I'll talk about that at the end. About that. I'll get to that, but yes. All right. So this is a lay website for patients, and I wanted to bring this up for a couple of reasons. One, for all y'all going out into private practice, if you are doing, this is probably one of the best resources for patients called HysterSisters. I don't know if any of y'all have used it, but my patients love it. You can get on there and find out anything you want about a hysterectomy, it's basically an open forum, and there's hundreds and hundreds and hundreds of thousands of women that get on there and blog and do all these things and exchange information. And the several patients that I've had that have used this come in with like really very concise questions. They have really good expectations post-operatively, and have probably done a lot better than other patients. So maybe not because of the website, but it's definitely helped. So this is a good resource, and on the front page at HysterSisters was this debate about morcellation and cancer risk. So it's out there, and your patients are going to be asking you about it the more kind of traction it gets. All right, so the first place I could find anything about morcellation in the literature on PubMed was a study from Allen, Edward Allen in University of Illinois. And I don't think he was actual operator of all these cases, but it was a case series about vaginal hysterectomy and morcellation with vaginal hysterectomy. And I guess from reading, I don't know the history too well, but I guess from reading, some people debated the safety of morcellation at the time of vaginal hysterectomy back when this case series was being done in the 30s and 40s. And so what Allen did is go back and look at these 640 cases and show that morcellation was safe. The biggest complication from the morcellation patients. They had double the risk of cystitis with vaginal morcellation. The interesting side note in this is that through their 640 cases, I got another number to put in y'all's head. Through their 640 cases, they had, I don't know why I have 8 and 1,000 there. Carcinoma was encountered 5 times. Now, none of these cases were sarcoma. They were all endometrial cancers.
Yeah, that was the concern, that you were going to spread endometrial.
Right. So many of these women did have fibroids too, because the article is about morcellation. So there was no cases of sarcoma in the 640 group of patients, and 5 cases of endometrial. So they were thinking about all this back then too. So this is not so when we talk about sarcoma and power morcellation, it kind of is similar to what they were thinking back then. So some other interesting parts of the article, just for historical purposes, is they mentioned some of these other people that employed morcellation. I don't even know how to say this guy's name, Pien or Peen in 1873 and Doyen 1895. And actually Dr. Lash was one of the rebuttals. So in these papers that are interesting, I never read a paper from this time period. They would have the article and they had like 3 or 4 doctors that would write in and they would publish their letters. And some of the criticisms were very, very, very harsh and poignant. And they would just publish those right in. And then they gave Allen, or I guess the author of the article, a chance to rebut everything at the end. And so Dr. Lash wrote in and commended him. And
so James, one of the things, Lash became famous for his morcellation, but he didn't enter the endometrial cavity. That was his big claim to fame, that it weren't going to spread adenocarcinoma.
Right. So I learned a lot of history while I was doing this. I thought it was interesting to pass a little bit out along. So again, I'm not going to go through all the articles. There's lots of articles in the literature about vaginal hysterectomy of large uteri and how safe it is. So I just wanted to put a few up there. And this is, when you search PubMed, there's lots and lots of these. All right, so let's talk about a few articles in particular. Okay, so this is from 1997. This is just a case study. 56-year-old nulliparous woman came in for postmenopausal bleeding. I thought this was a little interesting. The DNC showed complex hyperplasia, no atypia. They did a vaginal hysterectomy. She had a 14-week uterus, 250 grams. It actually did come back adenocarcinoma. And at the end of the paper, I thought this was an interesting comment. They said potential dissemination of endometrial cells is unlikely to carry adverse consequences and also does not warrant further surgery. So, not sure about that, but they didn't seem too concerned about it. So, first time morcellation, morcellation non-vaginally through a laparoscopic port comes up as in 1991. They came up with this, it's called the SIM, which is funny because the guy's name is Sim, so he sort of made the name fit, the acronym fit his name, which is, or he changed his name, one of the two. But anyway, he made this thing, and it looks very, very similar to what a power morcellator looks like, but basically it's a long cylindrical tube, and it had a cutting blade, and you would push it in the uterus and punch a piece out, so you get this long string of tissue, and you'd have to punch them individually. So, as you can imagine, this took a long time, but this was a better option at the time than doing an abdominal incision on the patient. So the SIM device gave rise to the first electrical cutting device, which is what the main topic of this lecture is, and that was done by Steiner. This would go on to become the Karl Storrs Rotocut, which is like a car engine, if anybody's ever held one. I peeled an orange with one. Me and Tamara peeled oranges with them, and they are extremely heavy. I'll show you a picture in a minute. They're extremely heavy. They're extremely powerful. They operate by a foot pedal. I mean, they're scary. So, and we'll go through some of the complications here in a minute. So this is the first mention of power morcellators in the literature, and this was by Steiner et al. He was the inventor of the instrument. I think later sold the technology to Carl Storrs. And you can read there in 1993. It claimed very big time savings. They just did a case series of 11 patients. It didn't, that was about it. And just talked to two really interesting comments from this article, which are, this one kind of foreshadows what we're about to talk about for the wrong reasons. But they thought one of the advantages of doing it this way and not pulling it out through a mini lap was if you did it through a mini lap, you might spread endometriosis and infection at the site of the mini lap, which I thought was kind of funny. And then the other thing, they talked about the instrument might be limited in ovarian malignancy, but nowhere in the article did they talk about uterine malignancy. So I thought that was sort of interesting. And we'll talk about that and bring in new devices and new equipment like mesh and everything else that we've talked about. And sometimes we don't stop and think about some of the possible adverse outcomes with all new technology like this. Oh, I can't talk. So I know some people in the room probably don't even know what morcellation is or have never seen it. And to be honest, I've not seen that many myself. So we'll just show a little video. Okay, so right here, this is the morcellator tip. One person holds this. It's usually through a 10, a 15, or a 20 size port. The other person, so it has a little grasp or the tenaculum that pulls the tissue up into the morcellator. There's a rotating blade inside this, and then you have an assistant that feeds the tissue in. You can watch, you can see how it goes. It sort of spins the tissue. And you can't see real well if you watch the video real close. You can see when it was morcellating the ovary, there was a sliver of ovary that just disappeared, and it did not go up into the tube. And so that's the point of this whole, so that was a very small specimen. That was probably this, the size of an apple with just 2 small ovaries. Imagine doing that on a big 20-week size uterus. And I've actually been to a course out in California where the guy did a supracervical hysterectomy on like a 20-week size uterus. It took him literally 15 to 20 minutes to do the hysterectomy. It was a video presentation. We were in a lecture hall, and it was teleconferenced. And it literally took him like an hour, hour and a half to use the power morcellator, going through like 2 different blades to cut this thing up. And after the procedure, he probably spent 15 to 20 minutes. And he talked about how important it was to go and try to find all the little specks. It was very, very tedious. So that's just a little specimen. Y'all can imagine with a big one how long that would take.
So did you like put the uterus back together like a puzzle? Like
No.
Out of the body?
And what's funny is when we went to these conferences, the guys would brag about how long of a section they could get. So basically you get these things going and it spins like a rotisserie. If you were cutting meat off a rotisserie, and when it comes out, you have this long piece, and they would brag how they would have their residents pulling these pieces, and they would brag that I had a 9 or 10 foot tube of tissue. But some of these guys are really good at it, but there's a huge learning curve, and it's very difficult. If anybody's been with Dr. Vandermolen, he's pretty good at morcellating the uterus, the fibroids on myomectomies. But y'all seen if he gets the calcified ones, it takes forever to cut up one little calcified fibroid. So anyway, that's what it looks like for everybody that has not seen that. All right. So this is kind of the landmark study that kind of gave some credence to doing power morcellation. And this guy down here, Macaris, is extremely well known. He's one of the pioneers in laparoscopy. He works at a Celebration in Orlando, Florida. It's one of the biggest centers for fibroids in the nation. He works for Ethicon now, but he's published lots and lots and lots of things. He's done thousands of laparoscopic cases. So anyway, he did the study back in 1997. They used the Steiner morcellator, which would become the rotocut, which we talked about, and this Wissop myoma enucleator. I could not find a picture. I could not find a description. I do not know what that is, but it was some sort of mechanical type device to debulk uterus and fibroids. So they showed an average time of 26 versus 79 minutes using these things. So that's quite a bit of savings. The thing I thought that was really also interesting, a side note about this study, is they quoted the OR time as $10 per minute. If anybody's reading the literature now on robotics and everything, when they always quote the OR time, it's about $110 to $90 a minute. So you can see what healthcare costs have done since 1997. So back then, when it was only $10 a minute, he did a cost analysis, and you had to do, I think, 15 or 20 of these before it would pay for the morcellator itself. All right, so that we'll fast forward now to a lot of articles that have come out in the past few months, and a lot of them have come out in the Journal of Minimally Invasive Gynecology, which is the journal for AAGL. So this one, electromechanical morcellation of minimally invasive gynecologic surgery. This was just an update and a broad overview. They did a literature review. Let me get my notes here. And basically, the premise of this, at first I thought it was going to be a little more profound. They just compared different morcellators. And when they were comparing sort of the performance of them. They would measure the speed, how fast they cut, all these type of things, okay? But one pretty good statement in the article was this: furthermore, it is remarkable that many morcellator devices are brought to the market without any published articles. So when they went through and did this, there's not a whole lot of articles comparing these things, talking about safety. Some of them have no articles published at all in the literature and are just coming out. And the reps coming by and people are just using them. And so we'll talk about what happens when that sort of event transpires. So just to give you all kind of what's available on the market now, there's more than this, but this is just a few. Put the popular ones. This was being pushed about a year or two ago. I think Dr. Unger might have saw that when you went to your PK course. They try to sell this. So this is called the plasma sword. This is the only one. This is the reason I put this up there. It's different from all the rest. The plasma sword has the tenaculum just like the rest. It has the tube, and you pull the specimen up into the tube, but the way this is different, it has bipolar energy that cuts. So it doesn't have a mechanical blade that cuts. It uses bipolar energy. Does anybody know what the problem with this is? Nobody uses it. It makes the largest amount of smoke. There is no smoke evacuator. There's nothing that you can do to keep the abdomen clean. And all these people at these big centers and courses you go to that do lots and lots of these cases hate this thing. So, and I'll show you all one of the complications from this earlier. I think the quote was, there was so much smoke I couldn't see, and there was some sort of injury or something like that. So one of the other devices is Wolf. They make the Kleppingers, I think. And y'all can see right here, this is a pretty big, it looks like a power drill. And so it's got this handle right here. It's got this long, this is where the motor is, and this is the tube. So you take your tenaculum, you put it down the tube, and it comes out the end, and then you pull the specimen up into the tube. And inside the tube, there's a rotating blade, and that's what causes it to cut. Same deal with the Carl Storrs. This is the one I talked about that's like a car engine. This thing is huge. It's probably about that big around. And you have to hold it with two hands. It goes through like a 15 size port, so you can't use it through a 10 usually. Usually you have to make a skin incision and put it through the skin. Like I said, me and Tamara peeled an orange with it, and you can peel an orange pretty quick. One of the things that I think is difficult about this as well, it really takes, you have one hand on the morcellator, one hand on the scissors, and then you have a foot pedal, which adds a whole other element into it. So I always find that things with foot pedals are a lot more difficult than with a trigger. So probably the most popular morcellators is Gynecare. There's a whole bunch of versions of the X-Track, Morcellex, Morcellex 2. They got a brand new one the rep was telling me about the other day. They have one that comes with a foot pedal and one with a trigger. These things are disposable. So it has a generator that's not disposable, obviously, and these come in a package. You just pull it out, plug it in, and it works. The problem with these are the blades dull. Sometimes you can have to go through two morcellators in a case just to get the specimen out. This thing was totally reusable, except the blades were like $300 a piece. I think this thing is about $600 or $700 a case. And that's why we didn't not do morcellation for large uteri here, because we were thinking ahead or knew all these things were going to come up. We just didn't want to go to the OR committee and asked Dr. Lee if he would give us a $700 morcellator to cut up our uteruses. So we've just been doing it vaginally. All right. So this is what's happened with morcellation over the past since 1992. This is power morcellation. So you can see the trend here. These are complications. So the incidence has gone up tremendously as well, and you've had all these complications going more and more and more. This trend also follows probably the trend of laparoscopic hysterectomy and laparoscopic myomectomy, and robotics being introduced somewhere in here too. Okay, so we're not going to go too in depth because we're going to look at the next slide, but this shows you, this is a data bank from, let's see. There are two FDA data banks. One was from 1993 to 1996, and then the other one started in 96 and picked up and got all the rest of the cases. These are the claimed injuries over that time period. At hysterectomy, 15 bowel injuries. So you can imagine if you pull a loop of bowel, what a morcellator will do to it. 15 vascular injuries, 3 genitourinary tract, and 1 death. Splenectomy, they've had 3 deaths. So you can see this is a big deal. It's catastrophic if you have an injury with this thing. This isn't like doing a lap hyst versus an abdominal hyst where the risk is, you know, getting a hole in the bladder or maybe a ureteral injury. This is catastrophic. And so when y'all do y'all's privilege packages, I don't know, Bailey, did they have morcellation privileges specifically on y'all's?
No, we didn't ask for it.
Okay, because I know this hospital, I know Willis-Knighton, Willis-Knighton, the privilege packet, it's morcellation and you need 5 cases that somebody will sign off on. So this is why. All right, so then they went ahead and listed all the complications. So I wanted to let y'all look at a couple of these. I thought this was, so in 2001, this doctor injured the kidney and the renal artery, and the reason was new instrument to doctor, he lost control. 6/17/2003, this is a bowel injury. Physician picked up the myoma and inadvertently picked up the bowel too. And you can read through all these, but I'm just going to read a few of them. This was aorta, vena cava, bowel, death. This is terrible. This was actually, they were trying to do it safely. The tissue morcellator penetrated the bag. And the reason I put that on there, we're going to talk about, you're all advocating that we use a bag. Well, this, I would argue, shows that that's not exactly going to mitigate the risk. This one, fallopian tube and omentum, surgeon lost visual control of the device during use. This is probably a bad thing during surgery, to lose visual control. And then 12/10/2009, iliac artery, probably not a good place. Limited visibility due to the electrical surgical smoke. So you can imagine which one that might have been. Surgeon's first case using the sword device, the plasma sword that I talked about a minute ago. So the abdomen got so full of smoke he couldn't see and he just kept on going. So some of this stuff is kind of dumb, but this is what happens when a rep comes to the office with a new device. Hey, try this out. Yeah, sure. And if you read through a couple, it's like one, proctoring physician with a physician for his first time, the new physician lost control, blah, blah, blah. So y'all get the point. All right. So that brings to evaluating the risk of electric uterine morcellation. So the incidence of use is unknown. We have no idea how often these things are being used. The only data we have is from that FDA reporting. The injuries are probably underreported in that reporting system, but that's all they have to look at. There's approximately 20,000 laparoscopic and robotic LSHs yearly. The reason I put that up there with an LSH, which is a laparoscopic supracervical hysterectomy, and a myomectomy, there's only one way to get the specimen out, and that's usually morcellation. I guess you could also make a incision in the posterior vagina and pull it out that way, or you could do a mini lap. Those would be the 3 options. They talked about no good method to detect sarcomas preoperatively. We'll get back to that. They mentioned an incidence of 0 to 0.49% in the literature review that they did. And in a separate morcellation case series, this was just incidence at hysterectomy, not fibroids. This was incidence with a actual case series of morcellation. They found 2 in 1192, so that came out to 0.2%. So there's another number to put in your head. They talked about morcellation in the bag, and then they went in real heavily about the informed consent process, and we'll talk about that in a few minutes as well. So this study was actually done by Seidman in 2012 at Brigham and Women's Hospital, which is Harvard. And this was just about the spread of atypical uterine neoplasms. So I was glad the oncologist came today because there was several of these things I'd never heard of, like stump and a couple other things, atypical ones that in this case series they didn't cause the patient to need it didn't increase morbidity or anything like that. So they looked at 1,091 cases of morcellation. They had 13 cases of leiomyoma variants is what they called it, or atypical lesions, or malignancy. So their rate was 1.2%, so that's a different number again. Again, this is not sarcoma. This is all comers. It's different than just a benign leiomyoma. So then they did a follow-up study of 7 in-house, so 7 of these 13, and then 7 consults that were sent after the fact of other people that had done morcellation and found cancer on the pathology diagnosis. So out of the 14, 9 of the 14 had dissemination. So 64% had widespread dissemination of whatever malignancy it was. And for the disseminations from the the bad ones, 3 of them had died by the time the study was published, and 1 was had a poor prognosis as well. And they calculate the average survival was about 24 months, and I would have to let the oncologist comment on that. Is that about the normal? What's it about the normal prognosis for like a stage 4?
For a stage 4 leiomyosarcoma, I mean that's probably about average or even less than that. Like a leiomyosarcoma patient, if they have stage 4 disease, they might live a year or 2. But I think the point is that if they hadn't been morcellated, then they would have been stage 1, and they probably would have had a much longer survival.
So, all right. Okay, so this is another video just to show you how profound the peritoneal spread. This video is very, very impressive. I'll kind of see if I can. Can y'all see that? Okay, so they're on the robot here. This is the Mayo Clinic, obviously. So right now they're poking around. So this patient originally had a myomectomy. So you can see an implant right there. That's a pretty good fibroid on the bowel. You can see this one that's recurred on the uterus. You can see this down, look at this down in the cul-de-sac. This one's really impressive down here. They're going to show you some in the broad ligament here in a second. And I'm going to fast forward a little bit, but they start actually running the bowel, and these things are everywhere. Thank you, Dr. Cooper. So here they're excising them. They don't actually show you excising, but here they start running the bowel. Watch this. When you start looking, oh, there's another one. So they're still looking around. There's another one. And they're taking these off one by one. You can imagine how big of a procedure this is, and the risk associated with this, taking all these off the sigmoid colon here.
How long before this had the patient had a myomectomy? I'm
not sure on this one, but I have a paper. I'm going to show you on the next one. It has some pictures as well that are similar to this. And I think it was, I'll have to look. I don't want to say the wrong thing. So anyway, y'all get the picture. These things are everywhere. I mean, they are literally. So you can imagine if that's a sarcoma or a cancer, it's all over the place. All right. Thank you, Dr. Cooper. Okay, so in the next paper, and you can find a lot of, like we talked about, there's lots of papers about morcellation case studies, a lot of case studies in the literature about spread, and this is just one of them. So this is Journal of Minimally Invasive Gynecology. This is, I think, this month. Oh, I'm sorry, this is 2007. 33-year-old underwent a laparoscopic myomectomy. So this is the before picture. You You can see the uterus is right here, and you can see this big old fibroid right here. And so what they did is they actually debulked the fibroid sort of in block. I guess they injected it and then morcellated it and then cut the remaining off and sewed it up. So this is 6 years later. Patient having issues again. So you can see an A. Let's see what A. This is the omentum. This thing is huge. It looks like a kidney. I don't know if y'all can appreciate that from back there. B is the round ligament. This is a pretty big tumor here. C is just the peritoneum, the left pelvic sidewall adhered to the ureter. And then D was just vesicouterine, so right on top of the bladder. So this is just from morcellation again. So like I talked about earlier, there's lots of case reports. This is just 3 more. So you can go through and do an extensive literature search and hear about everybody's experience with some of these patients coming back. So it sounds like if you do morcellation enough, you're going to get some of this.
So on that one, Dr. Unger said that the time between the first and second surgery was anywhere between 8 and 72 months on that chart.
Okay, and so this was so again, this was not cancer, this wasn't fibroids, this was endometriosis, and this was 5 years after a laparoscopic supracervical hysterectomy for a patient with pain. Came back with elevated CA-125 at a pelvic mass. They had multiple fibroids, adenomyosis, and endometriosis spread throughout the uterine cavity. So that's pretty impressive. What they said in the article, surgeons performing laparoscopic supracervical hysterectomy should take measures to prevent pelvic seeding at the time of morcellation and recognize the complication when it occurs. Easier said than done, okay? When you have fragments that are sometimes microscopic or just very, very tiny that go all over the peritoneum and slosh around in there after surgery, that would be very tough. Me and Bim, who lost a needle with me the other day? Oh, yeah, we lost a needle the other day. Just think how long it took to find that needle. We're just trying to find a speck, okay? So very, very difficult. All right, so getting sort of to the end here. FDA just came out with a pretty strong statement, and they say do not use laparoscopic uterine power morcellation in women with suspected or known uterine cancer. Duh. But then they say carefully consider all the available treatment options for women with symptomatic uterine fibroids. Duh. And they discourage the use of power laparoscopic morcellation during hysterectomy or myomectomy for the treatment of women with uterine fibroids. Discourage. ACOG is going to be a little more direct. So there's a whole FDA, I just pulled a little piece out of the FDA opinion. There's a whole long document on the internet that you can look at. Okay, so we're just going to go into the ACOG. It's not a committee opinion, it's just a statement that they came out with, and kind of go through this real quick. So they talked about risk analysis again in the article. That's how they start out. Post-op diagnosis 2 in 1,000 is what they give. Annual incidence is about 0.64 per 10,000. And they claim incidence estimated at 1 at 350 people undergoing hysterectomy. So
is that like this cancer as a whole? Is it?
Yes. This was annual incidence just in general was sarcoma, not hysterectomy or anything. This is not hysterectomy. This is just annual incidence of sarcoma. They claim was 0.64 in 10,000. This was patients that just came in and postoperatively diagnosed. This is patients undergoing HIS with fibroids. They said 1 in 350.
I think you've already sort of made the point also that it's not just the cancer that can cause a problem. I mean, the benign fibroids can get disseminated and cause problems.
So again, after my talk, I still don't know how I'm probably going to counsel patients on the risk of underlying malignancy at the time of hysterectomy, because we're going to talk about vaginal hysterectomy here in a second. So again, that's something that y'all are going to have to kind of decide on y'all's own. So the other thing ACOG goes into is pre-op diagnosis and evaluation. So they give some risk factors, which are not very good. Very broad. It's kind of like ovarian cancer. They feel full, their stomach hurts, and other real non-specific things. So one of them, like Dr. LaCour talked about earlier, was the risk of a growing pelvic mass, which has classically been associated with myosarcoma that grows very rapidly. But they also mention, as we've talked about before, if you look back in the literature, this is not an accurate, that's not how they present most of the time. So they say that, and then they say it's not really useful. They talk about women on tamoxifen or have had pelvic radiation, women with Lynch syndrome, renal cell carcinoma. The incidence is highest in 65-year-olds. They talk about perimenopausal, menopausal, and postmenopausal all around that time as high risk. They talked about women that come in with symptomatic fibroids that are perimenopausal. That's probably a big red flag. That's probably a good one to kind of keep an eye on that. They go into it. They've done some studies trying to preoperatively diagnose sarcomas and things like this from fibroids, and there's no real good way. They've done all this. They have imaging studies. They have all sort of markers that they're working on, and nothing has really panned out yet that I know of. They talk about use of a bag. They're a little more realistic about use of the bag. Jody had some fun with a bag the other day, trying to put a big ovary in it. So if anybody's used the really big, they have the endo catch and the endo bag, I think. One goes through a 15 and is the biggest bag we have, and it has a perforated edge around the bottom, so it's very hard to get. Dr. Unger struggled with it. I got to do it after y'all, I saw both of y'all struggle. It happened to me about a week later, coming threes. We went through 2 or 3 bags as well. So you put the bag in and try to scoop it up, and it's made to break away, and it pulls away from the perforated edges. The bag breaks away, and so then you're left with a bag without the specimen in it, and then you're pulling the bag out and putting a new one in. So that's one of the problems they talked about. There's nothing that can fit a 20-week size uterus in it that is on the market right now. So that's one of the limitations. The other limitation we talked about, I showed you on injury with a bag. It's just as easy. I've morcellated through a bag vaginally, where we took the bag, pulled it out through the vagina, and tried to cut it up. And I thought that would be so helpful, because if I ran into anything, you could run to the bag. But if you're back there with a knife, it's just as easy to stick the knife through the bag as it is to. So same thing with a morcellator. So my opinion on the bag thing is it's sort of a limited. It's got limited use, but it seems to appease some of the people that are kind of jumping up and down about all this. I think 2 of the big things that they talk about is informed consent and development of technology and training. So informed consent, again, you're going to have to pick the number that y'all decide to counsel the patients on. I think anybody that is at risk for having a morcellation, standard of care right now, anywhere, is they need an endometrial biopsy. Okay, even if you suspect fibroids, they need an endometrial biopsy if you're going to cut it up. Second thing is you need to ask the patient if they want you to morcellate their uterus. That's something, again, that I've not been doing that I need to do. Some women have come in, I think May Scott said it at her grand rounds when she came in, that some women are coming in and they do not want to have their uterus morcellated. They'd rather have an abdominal incision than undergo the risk of 1 in 1,000 or 2 in 1,000 or 1 in 400 or 1 in 350 or whatever you pick of that risk, and they don't want to undergo that risk. So again, it's our job just to let the patient know and ask them what they want to do. So if they don't want to do power morcellation, which we don't do here, but you may do in private practice, you can do it vaginally. You can do a mini lap, which I've done with some of y'all. You can take it out vaginally, or you can just open them up. So those are the options, and you need to tell them all the options, okay? Then development of technology and training. So the other thing ACOG came out very strongly in this statement was about surgeons using things that they're not trained to use. And so I think I talked about this at Grand Rounds last year with injuries on the robot, and we've talked about it with mesh, and we've talked about it with a lot of different things, but you just have to remember how big of a deal it is to pick up a new piece of equipment and go into the OR and try it out, okay? So with a morcellator, it can be catastrophic. With a robot, it can be catastrophic. It can be catastrophic with anything, but this is just a pretty clear example. They also talked about the need for a better registry. Again, most of these things are probably underreported. So the graph I showed you of all the complications, that's probably way underreported.
I mean, a lot of the information that we get in general about procedures that are done are from like ICD-9 codes, but there's no ICD-9 code for morcellation. Like you did a laparoscopic hysterectomy, that's all they know.
Right.
You know.
And so the other thing we talked about earlier was pre-op diagnosis techniques, and again, trying to identify patients, which I think is very difficult, and also maybe some basic science coming out or imaging techniques that can maybe steer us one way or the other about the risk of malignancy. All right, so I thought we'd have a discussion now. I don't know if anybody's seen the show, but if y'all haven't watched the first season, it's pretty good.
What is it?
Silicon Valley. So, a couple things I wanted to get some input from the faculty was, I was talking to Dr. LaCour about this in the hall. When we do vaginal morcellation, the attendings that have done it, we cut the uterus up, we pull off fibroids, and sometimes we stuff the uterus back up in the abdominal cavity and then grab the other side of it because we can't get it out that way. So we're cutting and sort of piecemealing it as well. So I don't think it's as bad as power morcellation because I do it. But, you know, what do y'all think about the risk of that?
But don't you think the risk, you know, with the power morcellation has something to do with the fact that you're just, and again, I'm not an experimental biologist, but that you're disseminating these tiny microscopic pieces and they're flying and hitting the peritoneal surface. And you know, we all know the peritoneal surface, peritoneum is very totipotential. I mean, it can turn into whatever it wants to turn into. And so, I mean, I get the feeling that it's more related to just maybe amount, you know, that you're just getting this.
You're creating like a cloud
you're
of
getting
cells,
this
you know?
overwhelming amount of we call it contamination. Whereas doing it vaginally, we're usually, you know, it's momentary, and then you're pulling it out, and you're not getting that cloud of burst of tiny microscopic cells, because I think it's probably the tiny microscopic cells that are the problem, not the big pieces. But so I think it probably has something more to do with this cloud burst against the peritoneal surfaces, because you know that's what the peritoneum is. You know, it can turn into whatever it wants to turn into. I mean, that's part of who it is.
I mean, I'd say your risk isn't zero,
Right.
you know, with vaginal morcellation, but I don't think it would be near what it is with the power morcellation and intra-abdominally. And especially if you're doing it laparoscopically, you have that abdomen filled with gas, it's under high pressure.
That's right.
Like, you don't have that when you're doing it vaginally
Right.
either.
But actually, I have had a patient with a vaginal morcellation who did not, she had a negative endometrial biopsy prior to surgery, and she was found to have a stage 1A, no myometrial involvement. So we did not give her adjuvant vaginal cuff radiation or pelvic. And she had a recurrence at the top of the cuff.
Yeah.
And it was a patient who had a morcellation through the vagina, and she did fine because it was an isolated recurrence. But I don't think the risk is zero with vaginal morcellation.
And that's the problem.
It's very hard though, because I've also seen patients, and I like your point about look at patient selection, because if you have a 65-year-old patient, you may feel different about morcellation, say if you had a 33-year-old patient, in terms of offering them that procedure and the way you discuss it with them. But one of my first leiomyosarcoma patients here in Shreveport was a young nursing student, lived in Alexandria, had a morcellation, and it was in the operative dictation, she had peritoneal dissemination. And she came up here 2 weeks after her surgery, and they had found postoperatively leiomyosarcoma. And we did a PET scan on her maybe a week later, and she lit up everywhere. And then I was able to get her to MD Anderson to try to get her in a clinical trial, and she maybe lived 1.5 years. But she may have had a different outcome if it had been confined. But essentially she was a stage 4 based on bad, maybe she would have done bad no matter what, and you just don't know. And that's sort of, I didn't see your SGO statement, but the SGO has put out a statement. And I don't love their statement because it ends with, these patients generally do bad no matter what, but that's really not the case. Some of them do very well. And I know Dr. LaCour has a few patients, and I do too, that had a stage 1 leiomyosarcoma. I saw one in surveillance yesterday who was diagnosed in 2006. A year before I got here, she had a hysterectomy, open procedure. They did it for fibroids. She had a leiomyosarcoma, and she's doing great. You know, if she had that uterus morcellated, she may not be here. So I think it's just a really hard, tough situation, and it really sucks if you're that patient. Yeah. And so I'm glad that it's out there, and I think one of the things that has really brought this to all of our attention is that a case in at Harvard you probably came across, where it was a physician who had a bunch of young kids. She was in her 40s, and her husband's a physician, and she may have passed away at this point.
She's still alive.
But it's, you know, it's hard if you have a patient that has this occur.
And Amy Reed was a doctor, the woman that had this, and she was a doctor and
educated.
She's an anesthesiologist, you know, educated. Has seen surgery, and she went to her gynecologist, and they never had the discussion. So, you know, if those two people are not having the discussion, then, you know, it's not happening anywhere. And
well, I think your other point that Dr. LaCour mentioned earlier is that even if it's not a malignancy,
yeah,
it can still develop really bad problems with disseminated leiomyomas. You know.
And I think, I mean, my personal feeling is I would discourage morcellation when you guys go out there. And one of the things Barrow and I have talked about is scars, and I love minimally invasive surgery. I mean, you guys know that. A lot of us as faculty try to do, whenever we can, a minimally invasive procedure. But Barrow was telling me about this paper about the different scar types, and if you actually look at what patients prefer, they don't choose a laparoscopy. A lot of time, what is their favorite?
There's several different studies, and it depends on the patient population, but this particular one, they preferred mini lap.
Yeah.
Over like robotic, which had high port. So they showed women pictures of scars, and in this particular study, they chose mini lap over everything else. The only thing they didn't choose mini lap over was single site. So
I mean, that's interesting to me. So if you discuss this with your patient, especially guys who are about to graduate next year, you know, there's nothing wrong with doing a laparotomy on these cases. If you tell me how you feel, Dr. Unger, but if you have a big uterine fibroid, there's nothing, don't try to be heroic and, you know, I can do this with a little incision. I mean,
and most patients with a big uterus like that, if they're that symptomatic, they're going to say, you know, whatever it takes to get it out. Like, give me a midline incision. I really don't care.
And so many people have C-sections nowadays. You just go through that scar, right?
And I think there's something to be said for, you know, what is the safest procedure you can do for that patient, and what's safest for the patient? I mean, you as the surgeon and them as the patient. And, you know, safety has to take the first place, and then from there, your skills and, you know, what's available to you. And obviously some of these tools are, I mean, they're fantastic tools, but they're putting our patients in danger, you know. And honestly, you know, I never really thought about vaginal morcellation until this came out, because that's, I mean, I'm not sure I can get a uterus out without cutting it to pieces. Especially some of these bigger ones. And I mean, I love the lash technique. It just sort of folds that uterus on out. But, you know, and obviously there is potential for spread for these problems, but the potential to me must be so low, because why haven't we heard about it sooner?
Yeah, and that's the other comment I was going to make, is we don't want to let the pendulum swing too far. And I do agree with some of the stuff you said, Dr. Black, about, you know, maybe not all just do a laparotomy, but there's not any case reports in the literature, I hadn't seen any, with vaginal morcellation, and maybe it's what Dr. Unger talked about, that cloud effect, or just it just kind of blowing it up and going everywhere. And so, but the problem is how do we counsel our patients? We do vaginal morcellation, and going forward, if they stop using these power morcellators, how do you counsel? What number do you tell your patient that the risk of vaginal morcellation, if in the face of unknown sarcoma? I have no idea. This is with a power morcellator. It's, you know.
Have you ever seen a reported case of?
I didn't see any in the literature. And I put vaginal morcellation in and looked through.
But I mean,
But I think you can counsel like that too.
Right.
Because we don't know what the risk is. We've seen it with this power
Right.
morcellation. We have not seen it with vaginal morcellation. You know, and I would tell my patient, I honestly believe this to be an extremely low risk, and this is a safe surgery for
Yeah.
you. And so I would definitely not err on the side of over.
And you have to put it in the grand scheme of things of surgery too. You know, they're having an operation that can get a PE and die too. And probably the risk of having a PE is more than having disseminated sarcoma. And so the last point I wanted to make and wrap it up is that when things like this happen in medicine, sometimes there's this tendency the pendulum swings too far the other way. And that's some of the criticism that's going on of Amy Reed and her husband at Brigham, is that maybe this is they're pushing too hard, and we need to take a step back and think about all these questions that we've talked about today and figure out sort of a common ground. Because he has basically said he was going to quit Brigham, and he was turning his privileges if they did not stop morcellation. Like, he just, that day, he wrote a letter to the newspapers and everything and said he was resigning.
I think that it's just like everything else, and you just have to take each individual patient and each individual circumstance and the surgeon's experience, and, you know, and like Dr. Black said, you know, it's like, it really depends on the situation.
You have to individualize.
The right patient. You know, if it's the right patient and the surgeon's had a lot of experience and you've done your endometrial biopsi preoperatively, then that's all you can do at that point. You know?
And also, when I look at the patients in terms of what incision I'm going to make if they don't have a known cancer, which most of my patients do, but I always think about the big picture. Like, how long is this patient going to be under anesthesia? What is their BMI? Are they going to be able to stand Trendelenburg? I mean, a lot of your approach depends on, if she's got a large penis, do I really want to make a big incision? Maybe it's worth taking that risk. I mean, I do have a group of patients that are referred to me because they're so heavy, and it's technically very difficult to do a surgery, and we do those.
Well, didn't you proctor somebody one time that it took them like 8 hours to morcellate a uterus or something?
Yeah. Yeah, I was really upset. I was like, yeah, I thought we were
And
friends.
so there's studies about that too.
She was a G0.
Yeah.
You know, it was her second case. I was proctoring, and the uterus was literally this big. I mean, it was, you know.
It was a robot.
It's a robot. And
I don't know
more
what
so,
you're talking about.
it takes, you know, it's quicker to do an excineration.
And there are studies. There are studies that show
More satisfied.
that
They never found the cervix, too.
there is a point
I
where
never found the
it's-
cervix.
oh my word.
I'm just saying.
There is a point of diminishing returns, I think, is the point there.
They found something they thought was the cervical ectopic cervix, and I was very upset by that. I was like, okay, we're never, you know. But yeah, I mean, these cases are hard.
I mean, and if you had done
And
it
they're not-
abdominally, it would have taken an hour, you know?
Yeah, it would have been an hour.
Well, I want to compliment you that we didn't get into the power morcellation business, because it's so easy, you know, when the salesmen come around, everything sounds so good. And, you know, we didn't get into that business with doing laparoscopic surgery, and I think you deserve a lot of credit for that. Because, again, for the people who are going into practice, these people are going to show up in your office trying to sell you stuff. And it's, you know, it's like the vaginal mesh business. Thank God we stayed out of the vaginal mesh business. And, you know, you just got to be very skeptical about a lot of these things that people will come and try to sell you. You know, you got to keep an open mind, but you've got to make sure there's some real scientific basis, support, literature behind some of this stuff, particularly as it regards patient safety. I mean, I think that's the big thing that we sometimes forget.
Well, I don't want to take all the credit for doing vaginal morcellation, because what I would do is call Tamara into my cases and make her get down between the legs while I stayed up top. So it's real easy from my perspective. But anyway, I think the biggest take-home message from this is to just, it's another thing to think about. It needs to go in the informed consent process, and it's a discussion you want to have with the patient. Like we all talked about, we need to individualize each of the patients and make a rational decision based on their presentation, their wishes, and let them decide and document in the chart. So thank you all, and